Hello, my name is Vera Alves and I'm a cardiac surgery CP at Southampton General Hospital. I'm going to talk about my service improvement project, which I developed in my clinical practice about gastric protection on discharge post-cardiac surgery. This was integrated with the Open University ACP Apprenticeship Masters and developed through my end-of-point assessment module. Why is this area so important in the cardiac surgery specialty? The evidence shows that gastrointestinal complications following cardiac surgery have an incidence of up to 3.7% and are associated with a high mortality rate, up to 33%. Gastrointestinal bleeding is the most common complication, with an incidence up to 18.5%. The main risk factors are advanced age, over 75 years old, prolonged cardiopulmonary bypass, the use of vasopressors, and comorbidities such as renal dysfunction and diabetes. These are risk factors that a significant part of my patients have. Oral anticoagulants are the leading cause of gastrointestinal bleeding, causing significant morbidity and mortality. Most of the cardiac surgery patients are in some sort of antithrombotic therapy, being with antiplatelets or oral anticoagulation or a combination of both pre and postoperatively. This, associated with the above-mentioned risk factors, makes this cohort of patients high risk of developing gastrointestinal complications and gastrointestinal bleeding. Evidence also shows that in patients receiving oral anticoagulation, the co-administration of gastric protection medication lowers total and major gastrointestinal bleeding between 22 to 44%. Given all these data and benefits above mentioned, there is a common misconception that gastric protection medications, either with proton pump inhibitors or histamine 2 receptor blockers, are not harmful and do not require any limitations. However, the literature also reports that these medications can cause several side effects and interactions. They interact with different pathophysiological pathways involved in the immune response, absorption of selected nutrients, bone metabolism. They can increase hypomagnesemia, incidence of fractures, and incidence of infections, can cause nutritional disorders, exacerbate cognitive impairment and dementia, increase major adverse cardiovascular events, and worsen renal function and diabetic neuropathy. They also interact with several medications that we give to our patients across specialties. Evidence also shows that between 40 to 55% of the patients in primary care in the US and the UK are inappropriately prescribed a PPI, with no evidence-based indication for their long-term use. PPIs are in the top 10 most prescribed medication between 2009 and 2019 in primary care, with a cost almost up to £99 million. So if in around 50% of the patients the PPIs are inappropriately prescribed, this cost could have been halved if there was better awareness and better criteria of which patients really benefits from these medications and their duration as well. This makes it necessary to limit the use of PPIs to the minimal duration and dose required. Nevertheless, in my area, the European Association of Cardiothoracic Surgeons recommends the administration of PPIs to all patients going through an open heart surgery. However, they do not present any guidance regarding which specific medications, their durations, their dosage, and which patients need gastric protection medications on discharge. This highlights a gap in the literature, which contributes to uncertainty amongst clinicians of which patients truly benefit from gastric protection therapies and their respective prescribing considerations. This gap creates variability in clinical practice, leading to heterogenic decisions, and this was what I observed in my clinical practice. We were all doing something different. There was no established criteria. There was no awareness of the risks and benefits of these medications. So this prompted the development of this project, which culminated in the elaboration of an evidence-based flowchart to guide clinical decisions regarding the indications and durations of gastric protection medications on discharge. To really be able to assess our practice and what we were doing, I conducted an audit on 200 post-cardiac surgery patients, and this is revealed that 30% of the patients were discharged on a PPI they did not require, and 30% of the patients were discharged on a necessary high-dose PPI, from which 12% didn't even require a PPI at all. To be able to analyze what the literature was saying, I conducted a systematic literature search and review. I used the PICO framework to formulate the question, the Prisma flowchart to streamline the literature. I analyzed the articles using a CASPA analysis. This allowed me to uncover the best available evidence regarding gastric protection post-cardiac surgery. This was conducted through PubMed, ResearchGate, and ScienceDirect databases to really announce a broader coverage and allow the selection of the best available evidence. I selected quantitative studies. I found 2 meta-analyses and 4 retrospective cohort studies. Then while analyzing through these articles, they often mention the only randomized controlled trial that was developed in the last 5 years, the COMPASS trial. So analyzing the literature, the 2 meta-analyses and the 4 retrospective cohort studies, they reached the same conclusion and provided the same advice. So they advise and support the routine consideration of PPI administration alongside antithrombotic therapies, especially in patients with high risk of gastrointestinal bleeding. So these patients are patients with age above 75 years old, history of gastrointestinal complications, concomitant use of medications that are known to increase gastrointestinal bleeding, like other antiplatelets, oral anticoagulants, NSAIDs, and steroids, and high-dose aspirin above 100 milligrams daily. This is also supported by the 2023 NICE guidelines. However, being 4 of the study's retrospective cohort studies, they had limitations, such as potential misclassification bias, reliance on prescription records, lack of adherence data, and unmeasured confounders such as lifestyle factors. The COMPASS trial was the only randomized controlled trial, as I mentioned above, and this didn't find really an advantage of adding gastric protection medication to oral anticoagulants. However, their population didn't have high risk factors, and they only used the low dose oral anticoagulants, which doesn't really translate the cohort of patients that we have in clinical practice that have high risk factors and use high dose of antithrombotic therapy. And so this was not really taken in consideration while developing the flowchart. The flowchart reflects the evidence that was defended by the 2 meta-analyses and the 4 cohort studies, and provides an up-to-date evidence-based tool for gastric protection prescriptions in post-cardiac surgery patients on discharge. This was approved by local governance, and targeted education sessions were provided to the cardiac surgery team for project dissemination and implementation. In terms of outcomes, immediately it is visible through peer review in daily clinical practice, improvements in gastric protection prescribing, with fewer patients being unnecessarily discharged with these therapies and reduced high-dose prescriptions. However, this compliance will be specially addressed in a re-audit scheduled for early 2026. This project demonstrates our advanced practice roles can drive evidence-based improvements in patient care by engaging with the relevant stakeholders and using leadership styles, emotional intelligence, core values, and education theories and styles to enhance the project's development, dissemination, and implementation. By informing gastric protection prescribing at discharge, the initiative is expected to standardize clinical decisions in relation to these therapies, minimize unnecessary medication use and costs, and improve continuity of care while promoting patient safety and reducing polypharmacy. Just to mention, while I was searching the literature, I encountered the American Gastroenterology Association Best Practice Advice from 2022 for PPID prescribing. They said 10 advices for either for a trial without PPI or when to stop the PPI, when to continue the PPI. And this is very useful across specialties, and I think is worth to have a look and searching for it, because these can help to create more awareness across specialties of which patients really benefit from these medications and which patients we are unsure and we might be able to give it a trial without PPI. And this way reduce risks and reduce costs. I hope you liked it, and thank you very much.